things with Miss Amber. First and foremost, as we were discussing previously, as far as with the active release versus the chiropractic adjustments versus the patterning. So taking into account that we've been working with Amber and we're freeing up the soft tissue adhesions that have developed in and around the tissue and in the various levels of the fascia, the way to make the condition and to improve it and to keep it permanent, the correction, is to create a pattern. So one of the things we're doing right now is doing a thoracic pattern for her, getting her to open up her rib cage, which allows that shoulder to function properly, and also creates more of a permanent nature in regards to the treatment. So we have her right hand on left knee, which is a neurological condition that has to do with the reflex sympathetic arc at the base of the brain, where her right arm's touching the left side. So it kind of goes back to that saying that the left side of the brain controls the right side of the body and vice versa. So we utilize that as a neurological tool to create a perfect pattern of movement so that the body will remember it going forward. So when she leaves here, she's moving and functioning more improved and better. So we're going to have her turn her head. She's going to extend back into this position. She's going to open up her fingers for me and give me the maximum amount of movement. And we're going to bring her back. Now, we're going to cross body again, crossing left to right. We're going to come back over to here, and then she's going to come back all the way to the left. Now, this is a pattern that you want to do, and you'll notice as we do this how the rib cage will open up and the actual arm will actually start to improve as far as range of motion. So we bring it back a few times. Again, I'm not pulling her arm back. I'm actually just giving her some general direction in regards to where the arm needs to go. There's a slight little deviation right there is where I wanted to correct. So now the actual shoulder's here. What she was wanting to do was this, which is very typical for patients to do when they don't really know how to move or they don't know what to feel. So we're just kind of teaching her to feel so that way she can get the correct movement pattern, again, that we're needing in order to make permanent success and changes. So again, we're getting into here, we'll change that again, and that's that range of motion that she's, and look, now I have all that range of motion. So very, very, very important. Now, she originally came to us and she had some neck pain and some shoulder problems. She'd been a few places to have treatment. Obviously she's here, so it wasn't quite as successful as it could have been. My opinion is that nobody was doing the active release on her, so therefore nobody had freed up those fibrous adhesions. So what we're going to do now is we're going to lay her on her back after creating the pattern. So go ahead and lie on your back for me, please. Good. Okay, we're going to get into the rotator cuff. You'll see me treat probably about 8 to 10 different structures inside the rotator cuff. I'll sit the patient up and then I'm going to work on that area of the neck. So she'll come across. We're going to start with the subscapularis muscle. She's going to bring it up. The key thing about active release is that it's active. So whenever you can encourage the patient participation and encourage the active movement of the patient, it's important to do so. You don't want to create all passive movements. You want that patient to participate. The reason being for that is more profound than just having them help me, because we certainly don't need the help. But what it does is the mechanoreception, or the nerve impulse for movement, travels faster than the impulse for pain. And two objects can't occupy the same space and time. So what happens is the actual movement helps diminish the pain response in the body. So right at that gatekeeper effect in the brain, the body's saying we're moving, and it's blocking out some of that painful nociception, which is the pain nerve, or pain nerve signal. So what I'm doing now is, again, just working this subscapularis muscle underneath here. It frees up pretty nice. Again, my contact, my line of drive is medial into the ribs, and I'm holding that subscapularis muscle down as she brings the arm over her head, again creating that active motion. Now I'm going to come into the pec minor. You can actually see how tight and rigid that pec is in here. That pec is tight. She does a lot of upper body work, moves her head, moves her arms around, so that tissue can become quite rigid. Go ahead and drop that down to the point to where she gets some pain in her neck and into that posterior shoulder. So what we're doing is working some of that pec minor. We'll work it, and what I'm doing is I'm feeling for lumpiness, stringiness, or even leather, if it feels like leather. The longer the adhesion is set into the tissue, the more fibrotic the tissue would feel. So a great way to, I always use the analogy of checking a steak. So when I'm feeling for a steak, you're feeling, again, if you use your hand to check for a steak or you're feeling the actual steak, the more well done the steak, the longer the adhesion has been there. So when I'm palpating my patient's tissue, I'm looking for, is it rare, like it's a new injury? Is it medium well? That means it's been there 6 months. And if it's well done, it's been well over 6 months that that patient has had that fibrous adhesion. Severity comes into it is when that adhesion gets so bad that it actually impinges or clamps down on a nerve. And patients will come in with symptomatology like I have a numbness or a tingling in the tissue, or my arm, my hand is numb, my feet are numb. So when that occurs, everybody automatically wants to assume that it's a disc, but most of the time, probably 80% of the time, it's an actual peripheral nerve entrapment rather than a disc injury or nerve root involvement. So again, working with Ms. Reed, we're just kind of going through all of these tissues. I'm going to have her give me a little external rotation of that shoulder right there for me, just to see what we got. Notice she's nice and back. There's not a lot going on with the shoulder. So we're going to leave that. So we treated subscat, pec, major, minor. What we're going to do now is roll her onto her stomach, and we're going to check the posterior shoulder. Go ahead and roll onto your stomach, please. Thank you. So posterior shoulder, the important thing to remember is that they're external rotators on the back of the shoulder. The front of the shoulder and the subscap is typically an internal rotator. That means it brings it across the body. The external rotators are in the back, in the posterior shoulder, right through here. Terry's major, which I'm on right now, is a structure, obviously it does this motion and aids in this motion, and it's the lat's little brother, and it helps the lat. So if there is a problem with the lat, which is a low back structure, the lat is often confused with an upper body structure when it's not. If I were to draw a line right here and say this is upper body and this is lower body, the bulk of the lat is actually in the lower portion of the body or in the back. The lat muscle is the best illustration of how it's all connected. So oftentimes a patient will come in and saying, I'm having shoulder pain, but we'll work down here into the lat and it'll improve the shoulder. The reason being is the lat, even though it's a low back structure, is attached to the humeral head, or it's attached to the humerus up in the shoulder. So again, that's a great illustration of how low back problems can cause a rotator cuff issue. Or vice versa. If there's a problem at the insertion site of the lat, that can have an impact on the lumbar spine because those adhesions and those fibers will stick. Left long enough, it becomes leathery and it becomes distal. So all of that tissue will become fibrotic and nasty. So again, I'm treating this Terry's major right now. I'm going to move over to the Terry's minor right here. So bring that back. The difference between the two structures is what they do. This one rotates that humeral head. So we're going to, my lovely assistant's going to rotate that humeral head down to get some rotation on that, in that area. Then what we're going to do is bring it back, and then we'll work it from a distal contact to a proximal contact. And again, I'm looking for those pieces that feel leathery. I'm looking for that area that doesn't quite have that relative glide or slide between the bellies of the tissue. So as we treat this area, I'm really looking for aberrant motion. I'm feeling for that well done steak. Right here, she's got a nasty little adhesion. That, you could feel that one, can't you?
Mm-hmm.
Yeah,
Yes.
Yes, that's good. It's not good that you feel it, it's good that you can locate it. And the patient will be is the expert on their body. They're a great indicator of yes, I'm on the area. So there's very little guesswork inside our facility. We try to remove as much guesswork and opinion as we can. We typically want to focus on fact, and that means using the functional movement screen, using the active release, and using the protocols that we set in place to be as accurate as we possibly can. Good, come back. Infraspinatus is the next one over. Same type of rotation of that humeral head. It's working a little bit more superior. She actually has an adhesion right there. You can feel that, correct?
Yeah.
Okay, good. And that's an actual, I hate to say well done piece, but that is a well done piece of tissue right there. So, very good. And rotate. So typically we make about 5 to 6 passes on each particular structure, depending upon where the adhesion is. And also, if it's pretty severe, you may have to make more passes over it, but if it's a minor type situation, we can kind of fix it. We're going to lie you back on your right side for me, and we're going to get into that hip. Nope, other side. Okay, so she indicated right now that she had some pain upon examination. Going to lift up your head, darling. So internal and external rotation of the hip. So what we're going to work for is piriformis, lamellae, which is deeper to it, obturator, glute med, which is on top, IT band, rectus fem, and then psoas. So we're going to treat all of those internal and external rotators, and also the glute med, which is a stabilizer of the hip. So we'll get right into that tissue. We're going to bend the bottom leg. She's going to shorten it. I'm going to take my contact upon it. She's going to lengthen the tissue. Now as we're moving this, she's lengthening the tissue through movement, which is going to free up those fibrous adhesions. Again, you want to make sure that you don't rush these areas. That sciatic nerve runs deep. It's a very thick nerve. As thick as an extension cord cable. So it's thick and it's definitely palpable. The big thing that happens with the sciatic nerve is that it sticks to the semimembranosus or the semitendinosus of the hamstring, and then right at the gluteal fold. So what will ultimately happen is that tissue will bind that nerve, and the symptomatology for that will be numbness, ache, tingling down the leg. So we have to free it, find out where those adhesions are, and then free them up. Traditionally, you want to try to work as many of these structures that have adhesions as possible, and to not have to overwork your thumbs or your body. Be as accurate as you can. So we're working these tissues in here. Good. And now let's go to quadratus lumborum, and I'll get into the rest. So, and bring her back into extension. And I'm lengthening the QL maneuver right here. Come back. And it's definitely a privilege and a pleasure to work on somebody when they're as flexible as she is. But right now I feel a pop and a click in her hip. You feel that too, don't you?
Yes.
Okay. And erectors. So now we're treating the erector spinae. We're going to have that patient tuck her chin to get more length on that extensor group. There you go. And again, she's back here. Now, we're using passive movement, Brina is, by pulling her leg, but we ask the patient to help her. The leg should be light. If Brina's feeling there's a lot of heaviness on the leg, that means that patient is not participating as much as they should, or maybe they can't. Maybe they have so much pain that they just can't initiate that movement. So with Amber, we're going to roll her forward, and we're going to treat the multifidus muscle. She's going to lean forward and let that arm hang right there. Multifidus runs deep to the spine. My contact is medial superior. As she rolls back, she's going to give me a big hug. Roll your arm back towards me, Miss Amber, all the way. Come back for me, just like we did in stretch. Good. And again, I'm right on what's known as the multifidus. So the multifidus muscle is a very common muscle to have for low back pain. It runs really close to the spine. Our workloads as Americans, this is a structure that really takes a lot of abuse. Roll back for me, please. Good, all the way, and we're going to twist. Good. Okay. So now we're going to let you right here for about 5 seconds. We're going to come up to the IT band and the TFL. Now the IT band and the TFL is right up to this muscle. It's an abductor of the hip. So, whoo. So it abducts the hip. It's tight right in here, and she's feeling this one for sure. And there we go. And that was that little pop that we had in there. So she actually has a fibrous adhesions at the superior portion of this IT band and TFL muscle. Ooh, there we go again. So a few passes on the tissue. Make sure that it's free. Good. And now we'll get into psoas and iliacus. Good. So with the psoas, it's a flexor of the hip. So you got to make sure, most of the time, most practitioners are too lateral. You got to be really midline in order to treat this muscle and structure. So you got to be pretty midline. There we go. And that was a huge release in that tissue. The actual hip itself just kind of freed up for us. Again, this is a primary hip flexor. In the body is the psoas. A very common injury. Probably one of I would say one of the worst injuries you could have would probably be to that hip flexor. Just limits motion, limits your push off, limits your long striding. So it just really can be quite cumbersome for an athlete to have a groin injury or a psoas injury. So again, we treated that. Now she also mentioned that she was having some problems in the knee, correct? The right knee?
Yes.
Okay, so come on, roll onto this side for me, please. Okay, so let me have the patient just demonstrate, because she's the expert. Show me where it hurts. Don't be afraid to ask.
Right here.
I have a tendency to ask the patient, show me with one finger where it hurts, so point with me for one finger. So there's no question of where she's getting that pain. Again, oftentimes if I said knee could be any of this, and any of this, that, or this. But she pointed and indicated for the back of the knee, correct?
Yeah.
Okay, so it hurts in the back of the knee and you get no pain on the front of the knee.
No.
Okay, it only hurts in the back.
Mm-hmm.
Okay, does it hurt with extension, or does it hurt with flexion?
Extension.
When you extend it. And does it hurt up or down?
Down.
Down. So it goes down into the calf?
Mm-hmm.
Okay. So we're going to change this body position, okay? I'm sorry to do this to you, but I'm going to have you lie on your tummy. And you can move that pillow out of your way. The popliteal muscle is a huge muscle. I find this a lot in the UFC because what happens is that popliteal muscle, as it comes in like this, it comes in like this direction. What it does is it provides stability to the back of the knee. When that muscle is compromised, athletes end up with something known as an AC tear or AC problem. So what we have to do is make sure that we treat the tissue. We're going to lengthen get on the hamstring portion of this, free this up, and she does actually have an adhesion. It's not quite giving me what I want. So give me some internal rotation of the foot. So we've shortened the tissue. We're lengthening the tissue right now, and then internally rotate that. This particular structure, the popliteus muscle or popliteal muscle, depending upon whether you're from Canada, is unique in the fact that it attaches out here underneath the lateral collateral ligament. Now why that's significant is that there is no attachment for the popliteus on the medial side, and the medial collateral ligament butts up against the medial meniscus. That's why there's more medial meniscus injuries than there are lateral meniscus, because the medial collateral ligament pulls the meniscus into the joint line and ultimately creates a situation where they pinch it and they rupture it. So it's very important to make an identification in this posterior knee, whether it be a meniscus or in a popliteal structure. So am I hitting that area, Amber?
Yes.
Okay, so you'd say I'm pretty much pinpoint right over top of it?
Yes.
Okay. And it doesn't feel too good, but you still like me, right?
Of course.
Okay. So it's important to ask that patient again for some feedback. Am I on the area? Although I palpate it, why not ask the expert? She's here, so let's ask her how she's feeling. So I'm going to leave that popliteal and I'm going to go back posterior on that joint line, and I'm going to work those hamstring attachment sites. So we got the membranosus and tendinosus coming down here. You got the sartorius, you got the gracilis, you got all these structures, IT band, lateral collateral ligament. So when someone says they have a knee problem, it can be extremely complex, it can be extremely difficult to treat, provided that you don't know the ART protocols. And then once you know the ART protocols, it's pretty good. So, okay, so we treated that. Move it around and see if there's any improvement to it.
Much better.
Much better, right? So it's articulating. When we first started, I noticed that she had a fibrous adhesion that would not allow, kind of allow that flexion of the hip. We're going to lie you back on your side, and the last thing that she mentioned to us was that she said that she had an elbow issue going on as well, correct? Good. Go ahead and lie on your back. And again, we're going to use the same true to form. Amber, please tell me with one finger, using your left hand, where is the pain in the elbow? Okay, so she's demonstrated the ulnaris side of things, or the ulnar side of things, Tommy John area. Remember, we have the brachial plexus coming down through here. So what we're going to do is treat the intermuscular septum first. We're going to find out if it's a push or a pull that she's getting the pain and discomfort. If it's something that we could treat pretty easily, or is it something that's going to need a little bit more attention with multiple treatments. But right now she's sliding pretty good. I can feel that nerve, and it may tingle a little bit underneath here. And again, to show off a little bit, I can kind of turn off that pinky. It's a great party trick. But again, what I'm working on right now is the ulnar nerve, and I'm palpating it to find out where the adhesions are within inside that those fibers. So right there is a little bit of an adhesion. I feel that that's not quite sliding like it should. Okay, so now I'm going to work on the ulnaris. So we're going to shorten that, and then I'm going to lengthen that underneath my contact. As I extend the wrist, have the patient extend the wrist as best that she can, and she's going to tell you that feels, it's kind of good in a sick way. Love, hate, good. Okay. Again, I'm using my ball to get more extension. That's kind of passive, so you really want to ask that patient to participate with movement as much as you can. But a lot of times they don't really know what you want, so I try to get as much freedom of that tissue as I can. So I use active and then finish with some passive ranges of motion. So again, we're getting right into that tissue. Notice there's no slide of my contact. I'm actually pulling with my fingers more so than I'm actually pushing with my thumb. You know, there's very little tissue. I don't harvest a lot of tissue right here, so it's pretty comfortable. I can apply a great deal of pressure on the patient and without very little pain. And it all has to do with the actual kind of the, if you will, the skill set of the practitioner does play a role. But however, it's how you get into the tissue from the start that ultimately determines the finish. So we're going to go right around this little process back here. This is the funny bone area. This is the area that if you ever bang your elbow, this is the area that kind of wakes you up and says, hey, I'm here. So there's our ulnaris. And you could feel that right there. And I'm right on it, and you actually have a nice adhesion. Her adhesion is proximal portion of this, and it's deep, and it's mid-belly. So she actually has some mid-belly. What have you been doing? You've been holding on to anything? Tennis? Anything you've been doing? What have you been holding on to? Like this? Anything?
Yes.
Okay.
When I work out bars and
Okay.
those type things.
So are you doing more of that? Okay. So I can determine that based upon her symptomatology, based upon what I've palpated and felt. I could feel that she's changed her workout to include more ulnaris type maneuvers, which is ultimately leading to a fibrous adhesion in here. So a couple more passes. Okay, so we've treated the ulnaris, we treated the hip, we've treated the shoulder. We're going to go up a little bit into the neck area. Go ahead and sit up for me, please. Scoot all the way down to the very end. Some of the primary positions in the neck, or structures in the neck, are the rhomboid. When the humeral head's pulled forward due to tight pecs, our flexion as American society, the rhomboid structures are lengthened, and that means they're just pulled upon all day long, nagging and aching. So what we want to do is we want to treat the adhesions that develop inside these muscles. So I asked my assistant for a little bit of help. Not that, and again, I'm holding the rhomboid inferior and medially, so as to break up the adhesions that have developed within inside the belly of that tissue. So I'm almost finished here. Come back. Bring that back. All the way across. Okay, so now we've treated the rhomboid. Lean your head back for me, please. We're going to go into a full flexion. So I'm holding our extensor group down. Look down for me. And come back. Brina, check Colton, see if he's done. I want him to do some soft tissue work on her one unit. So what I'm doing again is freeing up some of these extensor group adhesions that she has in here. Okay, hold the arm out to the side. Levator scapula is another structure involved in some neck pain, typically associated with whiplash or car accidents, slips and falls. Attaches to the top of the shoulder and up into the neck. You're going to bring the arm across for me, please. Turn your head to the right. And down. Good. And just kind of holding that structure, allowing her to go into right-sided rotation with flexion. Good. And come back. Again, levator scap comes down. I'm taking a pretty soft contact on it. She may not agree, but it is pretty soft. Go ahead and bring that across. And rotate and look down. So what we'll do again with this patient is adjust the thoracic spine. Can I have that? Thank you. Okay. And we're just going to, there we go. There we go. Okay. So now I'm going to have her lie on her back and scoot all the way up for me, please. Good. We're going to check the cervical area of her spine to make sure that those vertebrae are in place. And we got a segment right here, and a segment right there. So, okay. So that was the adjustment in the C-spine. We've got to see the hip, we've got to see the knee, we've got to see the elbow, and we've got to see the adjustments. So we've kind of covered all the patient's areas. The patient has pointed with one finger and indicated where those specific areas were. So it was very easy for me to find because I just listened to the patient. So is there anything else that you'd like to add? I do okay today?
He's the best doctor.